Okay, this is the second part of the lecture for mechanical ventilation. We're going to discuss common modes and capnography. So the learning objectives for this part of the lecture, we're going to talk about the modes and the types as well as capnography, how significant it is in terms of monitoring someone who is receiving mechanical ventilation. Again, the required readings. So as illustrated in the first part, these are some of the common modes of mechanical ventilation. Okay, and these are the standard abbreviations for those mechanical ventilation, and the full form will be in all the subsequent slides. Okay, so as I mentioned before in part 1, regardless of what proprietary names or brand names the manufacturer or patented names the manufacturers put on the modes, they all refer to one of these modes. Okay, and one of these modes are all the so-called generic names that have been created to describe the actual mode of ventilation. Okay, it's just that on different ventilators, sometimes a descriptor for that mode may mean the same thing as on another ventilator with a different descriptor, but they may all refer to, say, pressure support ventilation. Okay, so that's just an example, just because of commercial reasons. Okay, so I'm not going to talk about what each mechanical ventilator has, because it all depends on where you work. Contextually, you need to know how each of the mechanical ventilators in your workplace work, what modes are used, and how they describe the modes. Okay, so we're not going to go through that in terms of how to operate a particular mechanical ventilator. Okay, so common modes are these, and we're going to talk mainly about CPAP and PSV, then the very mandatory modes, the volume controlled ventilation and the pressure controlled ventilation, and then SIMV is the hybrid between machine breaths as well as spontaneous breaths. Okay, so we'll illustrate all this later in all the subsequent slides. So let's start with CPAP. Okay, that stands for continuous positive airway pressure, and it literally means the application of a constant or continuous positive pressure. So in other words, it is actually just one pressure, one single positive airway pressure. Okay, that is actually also then the baseline when you look at the pressure time graph. Okay, it is a spontaneous breathing mode. So anytime you see someone on CPAP, or you hear people saying, "Oh, this person is on CPAP, this person is on CPAP," that actually means spontaneous breathing mode. Okay, but of course CPAP may mean different things to different people. Okay, but in this context, okay, the true meaning of CPAP is indeed the application of a constant positive pressure, just one pressure. Okay, spontaneous breathing mode, as mentioned earlier or in part 1, it means that the patient can initiate all the breaths, can stop all the breaths. Here they can determine their respiratory rate, how long the inhalation time is, as well as how big or small their tidal volume is. Okay, it is at this point, it is rarely used as a mode of ventilation for adults. Okay, but in pediatrics, it is very commonly used. Okay, as both an invasive ventilation as well as non-invasive ventilation. Okay, the use of CPAP is not commonly used for invasive ventilation. It is more commonly used as non-invasive ventilation. Okay, in other words, it's given through a face mask, non-invasive. Okay, when it's invasive, we refer it to as when the person has an artificial airway, and an artificial airway can refer to an endotracheal tube or a tracheostomy tube. So graphically, this is how CPAP, okay, is illustrated, and I've already actually kind of illustrated CPAP in part 1 of the lecture in one of those graphics, but I'm just using another graphic to demonstrate that. Okay, so when we look at this part, okay, the top graph, again, these are all pressure time graph. Okay, and when we're looking at normal breathing, right here, this is what you and I are doing, okay? Airway pressure at 0, reference 0 at atmospheric pressure. This is what we are doing, okay? We breathe out, we breathe in. We breathe out, breathe in. Breathe out, breathe in, breathe out, breathe in. Okay? Along this time continuum. So this is what you and I are doing right now, or you are doing right now. Because I'm talking, then my breathing will be disrupted. But you not talking, sitting there watching this video, breathing quietly, this is what you'll be doing, normal breathing. Okay? Again, 0 reference to atmospheric pressure, and 0 being the baseline pressure. Okay? So this is the end expiratory pressure. The baseline is 0. Now, when we add a positive pressure of, say, 10 centimeters of water, okay, suddenly we're pushing your baseline from 0 to 10. Then it's said to have applied a CPAP of 10 centimeters water. So now, instead of you breathing on a baseline of 0, okay, imagine that you have to breathe on a 10 centimeters of water pressure as the baseline. In other words, you take a deep breath in, you let out about half the breath, and then you breathe at that whatever is left in your lungs. Okay, because whatever is left in your lungs exerts the pressure, and that's a new baseline pressure. So when this 10, let's just say 10 is added, then now your baseline pressure goes from 0 to 10. You continue still to breathe normally. Okay, it's the same pattern. Breathe out, breathe in. Breathe out, breathe in. Breathe out, breathe in. Breathe out, breathe in. And so on and so forth. So CPAP literally just changes the baseline pressure. Okay, so when this pressure is applied, just one pressure is called continuous positive pressure, airway pressure. That's the true meaning of CPAP. Okay, when you look at the graph below, this is a volume time graph. Okay, and now we are using this to correspond the pressure graph, pressure time graph above, the volume time graph below, and we look at each breath. Okay, you breathe out, your volume drops. Okay, you breathe in, volume increase. Okay, volume increases. Make sense? Yep. Breathe out, volume drop. Breathe in, volume increases. Okay, so this is what we call the corresponding pressure and volume in terms of the same time continuum. Yeah. So this is normal FRC. Okay, when you're breathing at a 0 of airway pressure. When we increase your airway pressure to the baseline of 10, okay, in this illustration, then now your FRC increases. Okay, which is what I've said earlier in the first part. What does pressure do? What does pressure do? The pressure actually increases FRC. And in this case, even though it's also termed as CPAP, this is also the baseline pressure, right? Okay, the baseline pressure of end expiratory pressure, or PEP, it increases FRC. Okay, which means it helps to prevent atelectasis from happening at the end of exhalation, and therefore it also helps to increase the surface area for gas exchange and therefore optimizing oxygenation. So this is CPAP. Now, contrasting this with pressure support ventilation, or PSV. Now, this is also a spontaneous breathing mode. So therefore, there are only 2 spontaneous breathing modes on all mechanical ventilation, okay, or ventilators. CPAP, the one we just talked about, and this pressure support ventilation. Again, the patient can initiate all their breaths, can determine their respiratory rate, how long to breathe in, okay, and also the tidal volume, whether it's high or low. Okay. But the difference between PSV and CPAP is that the patient's inspiratory effort or inspiration is actually assisted by the ventilator with a positive pressure. Okay, I'll illustrate that later in the next slide. Okay, again, can be applied invasively through an artificial airway, or through a mask, or through non-invasive ventilation. Okay. So graphically, Okay, this is what happens. Earlier, there's no pressure support. It's just one single pressure, the so-called CPAP. Okay, but in this case, the baseline pressure is set at 5. Yeah, but on top of that, we also set a pressure called pressure support. This pressure support supports the inhalation. Okay, but it is still the patient's effort in terms of initiating the breaths, determining whether how fast or slow they breathe, how deep or how shallow they breathe, and also the inspiratory time. And that's the reason why in this graphical representation, this pressure time curve, each breath varies in terms of when the person takes a breath. So it's not regular because the person the person determines when he or she or when they want to take a breath. Okay, so baseline in this case 5. So this baseline pressure is referred to as the PEP, the positive and expiratory pressure. Okay, it is sometimes used interchangeably as CPAP, but even though it's the same so-called baseline pressure, they refer to the same baseline pressure, but because it is no longer a single pressure, CPAP should not be used. The term, in this case, in pressure support ventilation, should not be used. Okay, I need to stress. Okay, so in true CPAP, okay, if you go back 2 slides before, there's only one constant positive pressure. But in positive support ventilation, there are 2 pressures. The baseline pressure, the PEP, and then also the pressure support that helps to support the inhalation. Okay. So when we go from left to right, when the person initiates the breath, this is the inhalation. The machine supports this up to this particular pressure and then cycles off. The person decides and then exhale. Breathe in. Exhale. Okay, so during the inhalation, a bit of pressure set, whatever number it is. Okay, let's just say this is about 12, right? If this number is 12 minus 5 is 7. So let's just say if the pressure support is set as 7 centimeters of water pressure, then every breath there is 7 centimeters of water positive pressure being pushed to help the person to breathe. Okay, but this is still a spontaneous breathing mode because the patient can still initiate all their breaths, determine the respiratory rate, determine the time taken for the inspiratory inhalation, and also to determine the depth of the breath, how big the tidal volume or how shallow the tidal volume. Okay, so this is pressure support ventilation. Okay, so I repeat, the difference between CPAP and PSV is CPAP is just one constant pressure. Okay, PSV, there are 2 pressures. The baseline pressure, the PEP, and the pressure support that comes in during inhalation when the person or when the patient initiates the breath during the inhalation phase. Okay, so pressure support, then this pressure that helps with the inhalation is also then called pressure support. Therefore, the term pressure support ventilation. Okay. So what does pressure support ventilation do? Now, when it was first created to overcome the work of breathing that is imposed through the ventilator valve system, the ventilator circuit, as well as the endotracheal tube. Okay, because when you have an artificial airway inserted, an endotracheal tube, it's like breathing a straw, like I've described in the first part of the lecture. Okay, when you have an endotracheal tube put in, the endotracheal tube is relatively narrow, and because of its length as well as its diameter, it imposes airway resistance compared to when you are breathing without an artificial airway or an endotracheal tube. So a group of anesthesiologists decided, let's add in this pressure to help the patient overcome the work of breathing that's imposed by the circuit as well as the endotracheal tube. So therefore, it helps to overcome the system resistance. Yeah, but then they also found out, it actually can also be used to help to support the person's ventilation. Okay, but in this case, because we've mentioned before and we've understand this mode as a spontaneous breathing mode, then the person must have a dependable intact respiratory center. So the person must be able to breathe spontaneously. In other words, initiate their own breaths, determine how fast or how slow they breathe, also determine how big or how shallow they breathe. Okay, but when you add more pressure in terms of pressure support, then the patient can actually breathe more deeply. Okay, and therefore it can also be used to help to support ventilation. We've already discussed the idea of PEP. I've already mentioned it is the positive pressure that is measured during exhalation or at the end of exhalation before the next inhalation. It helps with FRC, therefore preventing atelectasis or helps with recruitment, and because it prevents your alveoli from collapsing and maintaining its shape or integrity, the first surface area for diffusion of oxygen is optimized, and therefore it can improve oxygenation in addition to just providing supplementary oxygen through the increase of FiO2. Okay, so the illustration of PEP, again, pressure time curve. So this is regardless of whatever mechanical ventilator mode. Okay, if PEP is dialed at 0, then the baseline is at 0. So that's the person is then therefore breathing at atmospheric pressure, reference at 0. And if a positive pressure is added, in this case 5, then the baseline pressure becomes 5, PEP is 5, so therefore during exhalation it returns to this baseline pressure of 5. Okay. Now if you ask me, do clinicians put a patient on 0 PEP? Actually no. Most patients is arbitrarily left on the lowest of 5. Okay, just to make sure that your alveoli don't collapse, and it also helps to maintain because some physiologists believe that we have a physiological PEP of around 5 when you and I breathe, which is the amount of air that is left in your lungs at the end of exhalation, and that volume of air exerts a pressure within the lungs which is probably equals to about 5. Okay, so you will see that most patients, okay, almost every patient will have a baseline when they initiate mechanical ventilation. We always start out at 5 and then move up to by units of whatever, units of 1 or even units of 10 or 5s in to provide that increase of FRC or to optimize oxygenation. Then we've moved on from, we've discussed spontaneous breathing modes. Now I'm going to talk about the machine modes. Okay, the machine modes are the modes that provide all breaths as mandatory breaths. In other words, all the breaths that are delivered through these modes are all machine breaths. Okay, every breath is a mandatory breath type or a machine breath. Okay, and it can be delivered either by volume, so therefore termed volume controlled ventilation, VCV, or pressure controlled ventilation, or PCV. Okay, VCV versus PCV. Okay, there are different terms. They can also be termed as CMV or AC. So the most common descriptor of these modes you'll hear are AC, PC, assist control, pressure control, or ACVC, assist control, volume control. Okay, so these are the more common terms that you may hear people use to describe these two modes. But in actual fact, they are just VCV and PCV. Okay, why do they need to add the A or C? Because if a person is fully sedated and paralyzed, then the mode becomes fully controlled. So therefore, it's more controlled ventilation. And in this time and age, we don't always paralyze or sedate patients anymore. We do allow the patient to initiate breaths, to be more awake. So therefore, it is most of the time an assist control ventilation, which means the patient can trigger their breaths. Okay, even though we've set in a fixed respiratory rate. Okay, what does that mean? When we put in the setting, let's just say 12 breaths per minute, the machine will make sure the patient receives 12 breaths per minute. Okay, but the patient can also trigger the machine to deliver more than the 12 breaths. So you may see total respiratory rate on the machine as 20. Okay, so 20 minus the set rate, the example that I just gave, set rate of 12, then the 8 breaths are triggered by the machine, and therefore, or rather addition to what is set. Okay, but each breath, whether they are purely machine delivered or triggered by the patient, they are all mandatory breath types. This is a concept that you need to understand. Okay, when it's VCV or PCV, all breaths, whether they are triggered by the patient or not, they are all machine breath types. Okay, so let's talk about the controlled mode or the machine breaths that are delivered by pressure. Okay, the concept of the phases of mechanical ventilation that we talk about, the mechanical breath, when we have the initiate and then the limit, which is the inspiration. So if you go back to the slides in the first lecture, okay, this is the part where we set a pressure to limit the breath in addition to time. Okay, so the things that we will set for this mode on the machine, we will put in the set respiratory rate or frequency, the inspiratory pressure that limits the breath, okay, as well as the inspiratory time. So there are two limits to this this ventilation mode: pressure and time. Okay, so the pressure is reached. Let's just say the machine is set as at an IP of 20 centimeters of water pressure. Okay, then there is also inspiratory time that is set as 1 second. Okay. So the machine is triggered and the machine delivers the pressure to 20 centimeters of water, and then the inspiratory time will last for that 1 second before it cycles off to exhalation. Okay, so these three components determine the ventilation. Okay, or this minute ventilation, respiratory rate, and the pressure and time. Okay, the corresponding volume that is measured, okay, for this inspiratory pressure becomes the exhaled tidal volume. Okay. So notice in this mode, volume is not a set parameter, because in this mode, the volume becomes a variable depending on the person's lung characteristics. Okay, then these two components, the PEP and the FiO2, okay, determines the oxygenation. It helps with the oxygenation that we talked about earlier. Okay, the PEP increases FRC and therefore preventing alveoli from deflating, increases the surface area for gas exchange and therefore optimizing oxygenation. Okay. So what is this mode used for? Traditionally, when it first started, it was used to help minimize trauma related to pressure, especially for patients with low lung compliance, okay? Or which is low lung compliance means the lungs are stiff. So for patients with very stiff lungs, like ARDS, and we will talk about ARDS in lecture 5 when we talk about common critical care conditions. Okay. So graphically, you will notice that all pressure type ventilation. Okay, so when you compare this to the pressure support ventilation graph in the previous few slides, they look the same, right? Pressure time graph, and it's all squarish or rectangleish. Okay, square type waveform. So on a pressure time curve, when they are pressure delivered, whether it's pressure support ventilation or pressure controlled ventilation, the waveform will look the same, similar. Okay, square. What does this C stand for? C stands for control. Okay, just labeled here to illustrate that this graph, okay, is for pressure controlled ventilation. Do you always see the C on each ventilator graphic? Not necessary. Okay, and when we go through the labs and look at this on the mechanical ventilator, you would then know every machine has different interfaces. Okay, so they represent things might slightly differently. Okay, so this is a controlled mode. Okay, this is on the assumption that for this particular graphic, the person is sedated or paralyzed, which is very similar to when you are anesthetized on an operating table, when the anesthesiologist intubated you, and then your breathing is dependent on a mechanical ventilator. Same thing. Yeah, fully anesthetized or paralyzed. Okay, and these are the so-called set respiratory rate. At the set respiratory rate, when the time comes, the machine will deliver the breath. So therefore, you see the regularity in these breaths. The intervals and the time are the same because they are set to be delivered based on time. Okay, as I mentioned before, let's just say, for example, the respiratory rate is set at 12. Okay, so 12 breaths per minute, the machine will deliver 12 breaths for that minute, for every minute. Okay, 60 seconds in a minute, 60 divided by 12, then each breath will be delivered every 5 seconds. Yeah? Okay, so then you already know the baseline. Okay, almost every patient is arbitrarily receiving positive 5 of PEP. Okay, then the highest pressure recorded at the end of inhalation, that is the PIP, the peak pressure. And the difference between the PIP and the PEP is actually the inspiratory pressure. And in this case, it is set. It is a set inspiratory pressure, as mentioned in the slide before. What is set? Okay, we set the respiratory rate, we set the inspiratory rate, we also set the inspiratory time. Okay, so therefore you notice this are all the same because the inspiratory time are all constant. It's all machine determined and machine delivered. Okay, so this is pressure controlled ventilation. I'm going to move on to volume controlled ventilation. Okay, pressure controlled ventilation delivered through pressure. Now volume controlled ventilation, VCV, the breaths are delivered with a preset volume, a preset tidal volume, and the unit is usually milliliters. Okay, so this mode really ensures the set minute volume and minute ventilation. It really allows you to manipulate the ventilation because you want a certain tidal volume based on the person's ideal body weight, then you use this mode. Guaranteed delivery. Okay, now contrast this mode with pressure controlled ventilation. What is set? Okay, the difference. Spot the difference. I'll give you 2 seconds. Okay, this is the main difference. Okay, in pressure controlled ventilation, we set the inspiratory pressure. In volume controlled ventilation, we set the tidal volume. Okay, then you ask, isn't the flow rate different? Okay, the flow rate is different for most machines, but some machines, for VCV, instead of setting flow rate, you can also have the option of setting inspiratory time. Okay, so therefore the main distinction between volume controlled ventilation and pressure controlled ventilation is what is set. Okay, volume set for volume controlled ventilation, and then pressure set for pressure controlled ventilation. So this is a table that compares the pressure control mode versus the volume control mode. Okay, so you need to know what is the variable and what is the constant. Yeah, so on this side of the table, we have tidal volume, we have peak pressure, and then the effect of varying lung characteristics, whether it's the effect of low compliance, okay, the lungs getting stiffer, or whether it's effect of high resistance. For example, if there's bronchoconstriction. Okay, so the two asterisk points, these are the two main things that determine whether just by looking at the settings, you know that the patient is on a volume control mode or pressure control mode, and you don't have to look at the name of the setting. Yeah. So for volume control mode, so therefore the tidal volume is constant. Okay. If the machine is set to deliver 500 milliliters of tidal volume, then you will expect that exhaled tidal volume to be very, very close to, or if not the same as what is set, which is 500 milliliters, as an example. Okay. But the pressure will be different. Okay. Why is this different? Because volume is set, you don't set the pressure. So whatever peak pressure is measured is the corresponding pressure that it comes from the set volume. So in this case, if a person's lungs get stiffer, which means the person's lungs has low compliance, then for the same volume, the example I give you 500 milliliters, okay, you will need a higher pressure from the machine to deliver that same pressure. And then therefore correspondingly your peak pressure will increase. Then you will then register a higher pressure. Okay. Same thing, if the patient has bronchoconstriction or if there's a mucus plug inside the patient's airways that is imposing higher airway resistance, then in order for the patient's lungs to receive the 500 milliliters of tidal volume, you also need a higher pressure from the ventilator to deliver that volume. Okay, then contrasting that to pressure controlled ventilation, because the pressure is the one that is set. So your peak pressure that is measured should be the same as the inspiratory pressure, or should be the same as the sum of the inspiratory pressure and the baseline PEP of what is set. Okay, so let's just say that in this case we set an IP of 15. Okay, then the machine also has, oh pardon my very bad control of my mouse. Okay, let's just say the PEP is 5, right? So what's the total? 20, right? Total pressure is 20. Okay, so then the peak pressure that is on the machine should also read 20, therefore constant. Okay, now because this is the constant, then in this case the tidal volume is the variable. Okay, the variable because depending on the person's lung characteristics, the corresponding return in terms of exhaled tidal volume will differ. In this case, if the lungs are stiff, for the same pressure, the corresponding volume will be lower. Likewise, if there's higher resistance for the same pressure that's delivered, okay, there will be a lower tidal volume. So these are the main differences between pressure controlled ventilation and volume controlled ventilation. And you need to understand how they differ when the person's lung characteristics differ. Okay. Then I've mentioned now, then somewhere in between we have the so-called SIMV. That stands for Synchronized Intermittent Mandatory Ventilation, SIMV. Okay. Intermittent, okay, which means there is a mixture of mandatory breaths and spontaneous breaths. So in this case, machine breaths are set, whether it's volume controlled or pressure controlled. So if a person is on SIMV, then you can say, and the person is receiving volume controlled SIMV, then you may see on paper the respiratory therapists or the nursing colleagues or the medical colleagues may document this as VC SIMV or SIMV VC for volume control. Pressure control PC SIMV or SIMV PC. So it tells you that the patient is on SIMV and the machine breaths are volume controlled or pressure controlled. Okay, it cannot be both, either or. Intermittent suggests that then in between the patient is allowed to breathe spontaneously. Okay, so let's just say, again, I like to use the example of 12 breaths per minute. Let's just say example, this is the set rate. Okay, then in between the patient is allowed to breathe on their own, right? So you read from the machine, the total respiratory rate, okay, is 20. Okay, so of this 20 breaths, how many are machine breaths? How many are spontaneous breaths? Okay, simple mathematics. The 12 breaths are the machine breaths, then the remaining 8 breaths are the spontaneous breaths. Okay, and these spontaneous breaths, okay, are either on pressure support ventilation or on CPAP, but most of our time is usually pressure support supported, because I mentioned CPAP in adults rarely used as a mode on its own. Okay, so the spontaneous breaths are almost always pressure support ventilation. So therefore, there is a mixture of, for machine breaths, volume control ventilation or pressure control ventilation, with spontaneous breaths allowed. So there is also pressure support ventilation. So you can also add here as PSV. SIMV means there will also be pressure support as a setting being set for the person to breathe spontaneously. Okay, and what does this synchronize mean? This synchronize means this. Okay, the machine is delivered in synchrony with the patient's inspiratory effort. So if the patient is able to trigger the machine, then it synchronizes with, the machine will synchronize with the patient, and therefore patient initiates the breath, then the machine breath, if it's also the time to deliver the mandatory breath, the mandatory breath will be delivered according to what is set. Okay. This is very commonly used in post-anesthesia recovery units, where we are waiting for the anesthesia to wear out and before the extubation. And if the anesthesia is still retained quite strongly in the person's body, and therefore there may not be any inspiratory effort, the patient will still receive the mandatory ventilation at the scheduled time. But as the patient gets more and more awake, okay, then they can have more inspiratory effort, and then the machine breath will be delivered in synchrony with those efforts. The patient, of course, can also breathe more than what is set, and therefore those spontaneous breaths are pressure supported. Okay, so what this does is, as the patient gets more and more awake, the physician or the clinician might drop the set respiratory rate and then eventually switch this mode to a pure pressure support ventilation to allow the patient to breathe 100% spontaneously. Okay. So graphically, this is what it is. And for this particular graph, okay, you notice the shape is different. Okay, so this is actually a VC SIMV mode. Okay, with pressure support ventilation. Okay, why VC? Because for volume delivered breath, it looks like a shark's fin. It looks like this, a fin. Okay, compared to a breath that is delivered by pressure, which is a square wave. Okay, so shark's fin on a pressure time curve tells you that this is a volume delivered breath. A square wave on a pressure time curve tells you that this is a pressure delivered breath. Okay, so SIMV, using this graphic to demonstrate, yeah, again, set respiratory rate, and then you will see that how come some has no dip, some has a dip. Okay, so the labels up here helps you to differentiate. The C refers to controlled. So in this case, the patient has no trigger, but it is time for the machine to deliver the breath. So therefore, the machine delivers the breath. This is a 100% controlled breath or machine breath. Okay. Then the patient wakes up a little bit and then can initiate the breath. So the patient initiates the breath, take in suck in a little bit, yeah, creating this little dip. This little dip triggers the machine, and the machine says that, oh, it's also time for the machine to deliver the scheduled breath. So therefore, it synchronizes with the machine and delivers the breath. Exactly the same shape, same inspiratory time, okay, but we label this as assisted because the patient triggered, Okay, therefore it's assisted. But is assisted also a machine breath? Yes, assisted breaths are also machine breaths. Okay, because the patient only initiates the breath. Everything else is controlled by the machine or delivered by the machine. Okay, in between the patient becomes more and more awake, they take a spontaneous breath. So trigger a little bit of negative pressure to trigger the machine, then pressure support is being delivered. So this breath is a spontaneous breath labeled S. Okay, and then so on and so forth. Okay, so this is the whole idea of SIMV. Okay, so we've covered spontaneous breathing modes, CPAP and pressure support, PSV. We've covered the controlled modes, pressure controlled ventilation and volume controlled ventilation. And now we've covered SIMV, which is a mixture of controlled modes and spontaneous mode. Okay. Then, as I mentioned before, there are also other modes. There are also bi-levels, biphasic, and different manufacturers have their own different terminology, but they mean the same thing. Okay. And also there are also dual control modes that I'm not going to cover because it's a bit more advanced. So if you do work in an ICU or if you go into an ICU in future, then of course you will need to learn about all these modes that the patient might be on. But having said that, all these different modes are not commonly used. Okay, the modes that we just discussed, spontaneous modes, PSV, pressure control ventilation, volume control ventilation, and SIMV, those are the modes that are commonly used. Okay, sometimes when you see patients on different modes, it's probably because the patient is hard to wean off mechanical ventilation, and or the traditional modes cannot support the person's ventilation oxygenation, and therefore the doctors want to try some of these advanced modes. Okay, so it really all depends on the clinician's or the physician's preference. So these are some of the ventilator settings that you may encounter. Traditionally, we set at 10 to 12 milliliters per kilogram, ideal body weight, not actual body weight. Okay, ideal body weight is based on height, and you can Google online, and there's a table to associate what is your ideal body weight based on your height. Okay, because your lung volume or lung capacity is based on your height, not on your actual body weight. Okay. Most clinicians have moved to a lower volume ventilation to help protect the lungs so that the lungs are not over distended. That might cause the patient to go or rather that might subject the patient to volume trauma. Okay, so 5 to 6 or 7 or 8 milliliters per kilogram ideal body weight might be more commonly used nowadays. But again, it really depends on the preference of the physician. Okay, just know that these are some of the things that ventilator settings are used. I wanted to just highlight this. Okay, most of the time we always try to keep the peak pressure below 35 or 40 centimeters of water. Okay, and this is the same parameter that is used for the manual hyperinflation that you will learn for this semester or this trimester. Okay. This pressure is used to help to protect the lungs from over distended or to be subjected to pressure trauma. Okay, so the key term or the key parameter is always to keep the peak pressure below 40, and in some cases, some physicians might say to keep below 35. Okay, some points to remember before we move on. That machine breaths delivered by a mechanical ventilator can be controlled or assisted. It can also, of course, be spontaneous, but when I'm talking about breaths delivered by a mechanical ventilator, I'm referring to machine or mandatory breaths. It can be considered either controlled or assisted. Okay, then controlled breaths means everything is done by the machine. Patient does no work. An assisted breath is some things are done by the machine, and most of the time is just the triggering or the initiation of the breaths. Okay, but I stressed again, you need to know the difference between machine breaths and spontaneous breaths because it determines what you can do with the patient. For example, Okay, if a patient is only receiving controlled or assisted breaths, which means all breaths are machine breaths and controlled by the settings, then if you ask the patient to do deep breathing exercises, even though the patient is awake and can follow instructions and commands, it just doesn't work, right? Because if the machine is set to deliver 500 milliliters, no matter how hard the patient is trying to take deeper breaths, the machine will only deliver the 500 milliliters, and therefore the patient will only receive 500 milliliters. Okay, compared to when the patient is on the spontaneous breathing modes, which means the patient can then therefore determine their own depth of breathing, how fast, how deep, right? Then when you get the patients to take a deep breath, and if the patient can follow commands and instructions, then you can actually see the difference in terms of the exhaled tidal volume if the patient is on a spontaneous breathing mode. Okay, so this diagram may give you an idea of the spectrum of patient participation, which might help you to determine how much the patient can do in terms of level of assistance, whether you are taking care of the patient's respiratory aspects or initiating critical care rehab or early rehabilitation in the ICU. Okay, so more spontaneous modes means spontaneous breathing. Then the machine breaths, okay, no spontaneous breathing, all machine breaths. Okay, so in this particular diagram, when they use the term spontaneous breathing is different from what I've used. Okay, so please differentiate for this particular diagram. When they mean spontaneous breath, it's just initiating. Okay, when the patient is on assisted ventilation or controlled ventilation. Okay? Because as I mentioned before, in controlled or assisted ventilation, all breaths are machine breaths. They are not spontaneous breaths. Okay, but when the patient is switched to SIMV or on spontaneous modes like PSV, then yes, the breaths can be partially spontaneous breaths in SIMV or 100% spontaneous breaths if they are on PSV or CPAP. But as I mentioned before, in adults, usually no CPAP. It's PSV and then straight to extubation. Okay, removal of the artificial airway and then the patient, and then removal of the mechanical ventilator. I need to talk a little bit about non-invasive ventilation. So we mentioned before, it's just the application of mechanical ventilation without the insertion of an artificial airway. So it's through a mask, and the mask can be applied over the nose or over the entire face, covering the nose and the mouth. Okay, and these are some of the machines that you might see. So machines like this can only be used for non-invasive ventilation. They cannot be used for invasive ventilation. Okay, for invasive ventilation, you need those machines that I've shown you in the first lecture, in the first part of the lecture. Okay. So these are some of the interfaces through which a person can receive non-invasive ventilation. Okay, a face over the nose. Okay, prongs through noses, face, nose, face as in covering the mouth, the nose and the mouth. And then this covers the nose and the mouth as well, and so on and so forth. Okay, this particular one is hardly ever used, so forget about this. I don't think this is ever used. I don't even know why manufacturers actually produce these kind of masks, because you need to have a full nose block in order to use this. Okay, anyway. Okay, so illustrations of non-invasive ventilation. Okay, if it's through a nasal mask, the mouth needs to be closed in order to produce a closed circuit. Okay, pressure is being pushed in other words, air is being pushed in, and then this is also a positive pressure ventilation. Okay, and then you notice that for NIV, it's only a single tube. So where does the exhaled gas go to? The exhaled gas then go through a vent here that allows the exhaled breath to escape. Okay, so some general indications for non-invasive ventilation. Okay, when a patient has a do not intubate status but still needs may benefit from non-invasive ventilation. Okay, they may have severe dyspnea. Okay, non-invasive ventilation may be initiated first, again depending on the physician and some of these parameters. Okay, and this particular point, sometimes when the patient is being extubated, removed from mechanical ventilator, but they are not doing well breathing spontaneously. Okay, they may have more dyspnea, increased work of breathing. Then the physician or the team may start the patient on non-invasive ventilation. Okay, as opposed to intubating the patient again to see whether the non-invasive ventilation can help to tie the patient through this period of post-extubation period, and therefore save the patient the trauma of being intubated again. Okay, some of the relative contraindications for non-invasive ventilation. No need to memorize. This is just for your reference. Okay, just because I need to show this because some in some settings the physiotherapists are the ones that initiate and manage non-invasive ventilation. Okay, not so much in Singapore, but a lot more in Europe and Australia. So we feel that we need to include this in the curriculum to make our CP curriculum more diverse. Okay. NIV settings. Okay, NIV are spontaneous breaths. Okay, so spontaneous breathing mode. So they are either PSV or CPAP. Okay, so CPAP, one constant pressure that we've discussed. Then the other mode is actually pressure support ventilation. But on a BiPAP machine, on a non-NIV machine, we seldom use the word PSV. For whatever reason, the manufacturers don't use the word PSV. Instead, they use the word BiPAP. Again, BiPAP was once trademarked before. So BiPAP essentially stands for bi-level positive airway pressure. Okay, the inspiratory positive airway pressure and the end positive airway pressure. Expiratory positive airway pressure. What am I talking about? Okay, so the corresponding terms PEP equals to EPAP. The pressure support, okay, analogous to the IPAP. And then you can also add in supplementary oxygen. You can also set a respiratory rate for some machines, just in case the patient has periods of apnea. And then the machine can deliver the breaths according to these settings for the patient to back up. Okay, but that's only mainly for a backup system. It's not meant to support the patient's breathing. So that's NIV. So I stress, okay, you need to know the difference between invasive ventilation and non-invasive ventilation. And for non-invasive ventilation, most of the time is spontaneous breathing modes. And this is the most common mode. Okay, the BiPAP or the PSV. Okay, last part. Okay, capnography monitoring. Why is this important when the person is receiving mechanical ventilation? Okay, in part one of the lecture, we've already talked about, we look at the amount of carbon dioxide in the bloodstream to monitor the level of ventilation. So arterial blood gas, okay? And because of this relationship, right? We can manipulate the mechanical ventilation to increase minute volume or decrease minute volume in order to manipulate gas exchange, okay? But we don't take arterial blood from a patient all the time, right? Because when we breathe, it's breath by breath, right? It changes all the time. So how do we know the amount of carbon dioxide in the blood? So therefore, clinicians came up with carbon dioxide monitoring or non-invasive carbon dioxide monitoring. Okay, by monitoring the amount of carbon dioxide in the exhaled breath, okay, at the end of each tidal volume. That's the reason why it's called EtCO2. Okay, the EtCO2 values are usually slightly less than the actual CO2 values in your bloodstream, but the units are the same, millimeters mercury. Okay, so PaCO2 normal values 35 to 45, but PaCO2 ABG, okay, go back to revise, then EtCO2 normal values will say between 30 to 45. Okay, so most patients now in the ICU will have end-tidal CO2 monitoring, so that we don't always need to take an arterial blood sample and run an arterial blood gas to look at how the patient is ventilating. Okay, we can monitor the patient's ventilation through EtCO2. Okay, so there are two ways of doing it. Number one is always within the mechanical ventilator circuit. Okay, and this can be a electric sensor that immediately senses the CO2 and then transmit it, and then you see the graph as well as number on the screen. There are also EtCO2 sensors where it actually extracts the breath, the exhaled breath, and then do a moment by moment actual CO2 analysis. Okay, so these are the some different types of end-tidal CO2 monitoring devices. Most mechanical ventilators now provide that function of CO2 analysis. If that is not available, most ICU monitors will also have that function. Okay, so if the mechanical ventilator itself doesn't have that function, then that CO2 monitoring or capnography monitoring function is done through the ICU room monitors. Okay. So this is just an illustration of why CO2 makes sense, okay, in terms of the end-tidal CO2. Okay, so end-tidal CO2 means at the end of the tidal volume. So when you breathe in and you breathe out at the end, during the exhalation phase, especially during the end of exhalation, okay, the amount of CO2 in the alveoli and the amount of CO2 in the blood that is leaving the alveoli should equilibrate, should be about the same. Okay, so here. So, but because by the time this travels all the way to the airway, there might be some losses for whatever reason, and that's the reason why we say that CO2 is normally lower than what is actually in the bloodstream, in the small a, the arterial blood. Okay. Some illustrations of graphics. When you look at the graph, what it means, this is the normal one on top. Okay, this is this end-tidal CO2, and on the y-axis and then on the horizontal axis the time. The orange color means is exhalation, and then the inspiration part is in blue. So this is counterintuitive to what you see on the mechanical ventilator for breathing. Okay, so when you breathe out, your CO2 should be higher. Okay, and then this is the point where we measure the end-tidal CO2. Then when you breathe in, it doesn't detect any high level of CO2 because in the machine, when during inhalation, there should not be any CO2 in it. Okay, and then the next breath, next exhalation starts, and then inhale. Okay, so these are just two examples of what might happen. The most common is actually the one at the bottom. No, don't worry too much about the one in the middle. Okay, in the interest of time, I'm just going to skip this. The one at the bottom talks about hypoventilation. Okay, what happens when your ventilation is not sufficient and therefore CO2 starts to accumulate within your bloodstream? Okay, then what will happen to the end-tidal CO2? What you will see is the end-tidal CO2 should then will increase, right? Because your PaCO2 accumulates in the bloodstream, so therefore your EtCO2 correspondingly will also increase. And this is what this graph suggests. Then there is an increase in CO2 telling us that the patient is not ventilating sufficiently. Okay, so this wraps up the second part of this lecture. Okay, again, prepare yourself for the lab. And in the next part, the part 3, or much shorter lecture, much shorter recording, we'll talk about some of the principles of breathing or mechanical ventilation, as well as the effects of mechanical ventilation on your cardiopulmonary system.